Hello, dear friends. Good evening. On behalf of Diabetes India, me and Dr. Amit Gupta, I am as secretary and Dr. Amit Gupta, joint secretary. We welcome you all. First of all, I would like to thank Diabetes Education Study Group, which is a very important study group of ESD, European Association of Study of Diabetes. I'm particularly thankful to Tajana for this opportunity to collaborate with Diabetes Education Study Group. As such, we are collaborated with them since long, must be more than 10 years or 15 years. I know Dr. Shokat Sadikot was very close to Tajana, and many of you, Florian and everyone know him. And in 2013 onward, we regularly have a DESG symposia in our annual meeting of World Congress of Diabetes in India. We also have participated in DSG symposia, which they do annually in ESD, and someone from India always represents. This time, we thought of to have some collaboration with two associates to do an online meeting. Particularly, we are targeting Indian audience, the idea of that we don't have educator in most of clinics. We have 100,000 physicians who are treating diabetes, but in educators, we don't have similar number. Because of large number of people with diabetes, education is something which require more time for our patients. The doctors are busy enough and they just prescribe the endocrinologist, physician, diabetologist, and we want to improve education and more educator. And even those who are doctor, even they can educate their primary associate, maybe a dietitian, maybe an assistant doctor as an educator. That's an idea of creating an education system in our diabetes India. This online meeting, which we have circulated this flyer to almost 100,000 physicians, and many doctors have registered for this meeting. This online webinar, after this meeting, will be also on our website, and we will have a regular meeting with DSG and other organizations from where we have collaboration. So last time we have done one meeting. Now we are doing with you. We are going to do with Korean Diabetic Association. We are going to do with Primary Care Diabetic Association. So some international organizations we are collaborated. Regularly we invite them for our World Congress, and we will be having some online meeting. We will have our World Congress of Diabetes and Obesity this year in month of Feb, which is from 13, 14, 15 of Feb. It is at Hyderabad International Convention Center. With these words, first, again, I invite Dr. Tajana, and I want to thank her profusely from Diabetes India, and inviting her to introduce our speakers, which she invited from Diabetes Education Study Group. Before she speaks, I will request Amit for a few words, and we will be there with all of you in next 1 hour to listen, and then we will have some discussion. There may be many questions, but we will filter out some questions to Tajana, and then we will discuss those questions. We will keep this webinar recording on our website, so people who are not joining today live, they can listen it later on. With this, now I request Amit for a few words, and then I will request Tajana to introduce DSG first, and then to talk about all the speakers. Over to Amit.
Thank you, Dr. Bansi Sabu, for introducing the panel as well as the webinar. And it is really very nice to see this collaboration happening and being running successfully for last so many years, and in fact, we can say decades. So welcome all the faculty members from the DESG, and we welcome all the participants who have joined us live for this webinar. And as just to mention that diabetes education is often overlooked, but it is still, I believe, the cornerstone for diabetes management. And I'm sure so many exciting topics are lined up, and it will be a great learning for all of us, and it will help us in gaining some knowledge, which will improve our patient outcome and the care. So welcome, Dr. Tajana, and it's over to you. And you can introduce DESG and the panel, and then we can move ahead. Thank you.
Thank you so much for your kind invitation until now. It's our pleasure, like Diabetes Education Study Group. So I really want you to thank all of you to be our partners this many years ago in our fight against diabetes. As Dr. Amit said, diabetes education is one of the cornerstones of diabetes treatment, and that's why we are here together, because we all believe that really this is the one of the most important part of the diabetes treatment. And it is our pleasure because Diabetes India is a huge organization, and it's really good opportunity to spread the idea for diabetes education and to share our knowledge and experience with all your doctors in India. So I'm sure that it is just a beginning of our collaboration that will continue in our many next another project that we will plan in the future. So today we prepared as a diabetes education study group very interesting program, and I would like to introduce our speakers, professors, and our members or group. First, we'll start with Professor Svetlana Tankova from Sofia, Bulgaria, and she will speak about the advances in diabetes management, clinical and practical perspectives. Then Professor Florian Toti from Albania. He will speak about lifestyle and behavioral intervention in diabetes care. And finally, Professor Cornelia Bala from Romania, and she will speak about behavioral modification and patient motivation techniques in improving mental health in diabetes care. So I really believe that you will all enjoy this very interesting topics, and also I believe that we will have a lot of questions and very fruitful discussion to the end of this webinar. So I'm leaving the floor to Professor Svetlana to start with her presentation. Thank you. Professor Svetlana, can you hear me?
Yes. Yes, I'm hearing you.
You can start, please.
Yes, we can see your presentation. Just put in the presentation mode.
Okay. Thank you very much, dear Dr. Banshi Sabo, dear Tanya, dear colleagues. It's really a great pleasure for me to be part of this meeting, Diabetes India, in collaboration with Diabetes Education Study Group. So really a great pleasure, and thank you very much for the invitation. And I have quite a challenging topic today, and this is advances in diabetes management, the clinical and practical perspectives. This is really of importance, and we are living quite in exciting times now. These are my conflicts of interest, and I will start speaking on the advances in diabetes management, focusing on what we have achieved and what are the advances during the last years or decades in type 1 diabetes, in type 2 diabetes. Starting with type 1 diabetes, there is technology which is part of the current management of type 1 diabetes. And I will bring you back some 104 years ago for the discovery of insulin and for the first injection of insulin, which was injected to a dog at that time. But thereafter, it is a life-saving medication. And we all aware about the Nobel Prize, which was awarded to the 4 discoverers of insulin in the beginning of 1923. So many years, over 100 years since then, since this Nobel Prize, and there is quite a strong evolution of insulin therapy for this time. If we start with insulin at that time, injecting insulin with a syringe, the conventional insulin therapy, going through the intensive insulin therapy, the insulin pumps, the sensor augmented pumps, and coming to the artificial pancreas or to the closed loop systems currently available. So what about the insulins over time? There has been a lot of research and a lot of development, and all these rapid-acting insulin, they are becoming shorter and faster acting. We have a lot of achievements and advances in this field. And for the basal insulin, we have now insulins with longer action, with flatter profile. So a lot of development during the years. What about the future of insulin? What we are looking forward to the so-called smart insulin with built-in glucose sensitivity, so that insulin is delivered according to the level of glucose in the blood. What about oral delivery? I think for decades we are dreaming about the oral insulin. What about the tissue-specific and targeted insulins, the liver-specific ones, which is also very important? And of course, we have something which is currently available, the once-weekly injection, which is also quite good for the compliance and for the glycemic control. A lot of advances in the injection devices, starting with the syringes for multiple use, then moving through the pre-filled and through the pen fills, the pens, and currently coming to the insulin pumps. The insulin pumps also a lot of achievements and advances in this field, bringing you back more than 6 years ago to the first insulin pump, then coming to the first wearable pump, and currently even to the tubeless pumps, which is a great achievement and decreasing the burden for people with type 1 diabetes. But we have also a lot of advances in the glucose control, in the way we assess the glucose control of people with diabetes. We have the hemoglobin A1C, which is in practice for so many years. But when we look at the hemoglobin A1C, it does not give us any information on the glucose variability. And that's why it is not the same to drive one or the other way. It's quite more difficult and much more complicated if we go the other way, not driving that right ahead. So the continuous glucose monitoring systems have also entered our everyday clinical practice. We have different types of CGM systems which help us to assess the real glucose control of people with diabetes, with type 1 diabetes. Some of them are available in some of the countries, others in other. And we have an international consensus, which is over 80 years old, international consensus on the use of continuous glucose monitoring. And we now know what parameters to look for when we use the CGMs. And all these time in range, we have also consensus, international recommendations on the time in range. And we need to look not just at the hemoglobin A1C of people with diabetes, but also at the time in specific range. So we have even a much more strict range. We have the target range. And this is quite important for people with type 1 diabetes. So there is a lot of achievement, a lot of advances in the field of assessing the glucose control of people with diabetes. And I would like to go through what are the achievements, what are the advances in insulin therapy for people with type 1 diabetes, starting with the discovery of insulin, then going to the first insulin pump, to the first commercial pump, which was in 1980s, then the first CGM 1999, then the sensor augmented pump in 2006, then the low glucose suspend and the predictive low glucose suspend sensor augmented pumps you see over 10 years ago, the first dual hormone hybrid closed loop system some 10 years ago, the commercial hybrid closed loop system in 2016, then in 2019, another one. And here is a series of these commercial hybrid closed-loop systems, which are currently available in some of the countries. And we are looking forward to new indications for this technology, which has entered our everyday clinical practice. So a lot of achievements, a lot of advances in the field of insulin therapy as a life-saving therapy for people with diabetes. What we are currently very much interested in are the automated insulin delivery systems, which have a glucose sensor, an insulin pump, and a closed-loop algorithm. And there is also a consensus on the use of automated insulin delivery technologies, with the experts in the field having prepared these consensus recommendations. And there are currently 6 such systems which have been approved, and some of them being available in some countries, in others, with different algorithms, with different indications for people at different age. And I will bring your attention to one of these hybrid closed-loop systems, which is the Minimed 780G, which is a 2nd generation Minimed advanced hybrid closed-loop system, which has recently in this year been approved for people with type 1 diabetes aged 2 years and above, and also for people with type 2 diabetes and people with pregnancy. So it is quite a useful tool in our everyday clinical practice. We have in my country, we already have some experience, and I might tell you that we have even patients with 100% time in range, which cannot be achieved with any of the other technologies which we have available in clinical practice. And another achievement, another advance in this automated insulin delivery systems is the iLet bionic pancreas, the first bionic pancreas, which consists of 2 infusion pumps, and it has been cleared 2 years ago by FDA for people with type 1 diabetes. So we are moving forward, and there are a lot of benefits of these automated insulin delivery systems. They increase the time in range, they reduce hypoglycemia, improve hemoglobin A1C, but what is most important is they improve the quality of life of people. They reduce the burden of diabetes management, and they even have it was found out that they even have long-term cost savings. We are nearly there to the fully closed-loop insulin delivery. We have been dreaming for this during, I may say, the last decade or so. And there are currently 2 such fully closed-loop insulin delivery systems. One of them is the bihormonal fully closed-loop system in Reda AP with glucagon and insulin being delivered, but also the CAM-AP SX-HX system, which have been approved one year ago. So fully closed-loop insulin delivery is quite close here, and it is a great advance in our clinical practice. It is recommended that these automated insulin delivery systems are offered for diabetes management to youth and adults with type 1 diabetes. So we need to offer this if it is available, if it is affordable, because it has a lot of benefits for people with type 1 diabetes. But there is something else with type 1 diabetes. Type 1 diabetes has been found to go through different stages, through stage 1, stage 2, and stage 3. These are stages with normal glycemia, dysglycemia, and hyperglycemia. And we need to look for the earlier stages of type 1 diabetes to screen for them in people being relatives of patients with type 1 diabetes, because we already have a tool, we already have something anti-CD3 monoclonal antibody, this is teplizumab, which on the basis of this study, which I am showing to you, has been found to be the first disease-modifying therapy in people with type 1 diabetes, being approved by FDA just 3 years ago for delay of stage 3 type 1 diabetes in adults and children over the age of 8 at stage 2 of type 1 diabetes. So a lot of advances in type 1 diabetes management. But this was up to here for people with type 1 diabetes. We need to look at people with type 2 diabetes as well. And I'm bringing you 10 years ago, when the results of the EMPEREC outcome were first reported at a meeting of ESG in Stockholm. And it was the first time when we found out that a medication, a drug which has been developed for the treatment of people with diabetes, it has been designed as a glucose-lowering drug, but it was demonstrated that it can decrease mortality in people with type 2 diabetes. And this is quite an important trial which opened the field for such great advances in the field of treatment of type 2 diabetes. And we are really living in quite exciting times. And on the basis of these cardiovascular outcomes trials, we don't have time to go in details in the different trials. I was part of the team which prepared the consensus report of ADA and TSG, which was reported in 2022. It is currently being updated, and you'll have the new update next year in a year's time. And it was in this consensus report that the holistic person-centered approach to type 2 diabetes management was implemented. So we have 4 main components of care, a lot of principles of care, but we put in a circle the glucose management, the weight management, the cardiovascular risk factor management, and the cardiorenal protection. They are in a circle because they are all equal. There is not even one component which is more important than the other. And we see here that we have a lot of options for treatment and for achieving the goals of care, to prevent complications and to optimize the quality of life of people with type 2 diabetes. And this is the table which we are used to present at almost all our presentations. And you see here that we have people who need cardiovascular risk reduction, people at high risk, and people in whom we need to achieve the glucose and the weight management goals. And we have 2 groups of medications here, which are quite important in people at high cardiovascular risk, people with CKD, with heart failure, with atherosclerotic cardiovascular disease, and indicators of high risk. And this is for the first time in this consensus report when the medications for glucose lowering were stratified according to their efficacy for glucose lowering and for weight loss efficacy. And it is really what we are discussing during the last years, that there is really a paradigm change. There is a paradigm shift in the current management of type 2 diabetes. We are now no longer glucose-centric. We are currently thinking about the cardiovascular benefits, about the renal benefits, and about the metabolic benefits in people with type 2 diabetes. We now have glucose-lowering medications which have indications for cardiovascular disease and for chronic kidney disease. It is really a paradigm shift, and we need to consider this in our everyday clinical practice. And all this happened just because we have the results of the big cardiovascular and kidney outcomes trials. As I was discussing with you about the technology and the place of technology in people with type 1 diabetes, what we included in the guidelines in this consensus report in 2022 was the place of technology in people with type 2 diabetes. And we found out that technology can be useful in people with type 2 diabetes, and it needs to be part of the holistic approach to people with type 2 diabetes. And also we included here to consider CGM in people with type 2 diabetes on insulin. So technology is there in people with type 2 diabetes as well. And it is considered one of the advances in diabetes management. As I presented to you, that one of the hybrid closed loop systems has been approved for people with type 2 diabetes during this year. We also have a different consensus guidelines from other societies, from European Society of Cardiology, and they are also guiding us what to do and how to treat people with diabetes at different cardiovascular risks. And here are the two groups of medications, the innovative drugs, the SGLT2 inhibitors, and the GLP-1 receptor agonists. But there is another society, and these are the KDIGO, our colleagues nephrologists, with the therapeutic approach in people with type 2 diabetes and chronic kidney disease. And we can look here at the first-line drug therapy that SGLT2 inhibitors are here, and we see the GLP-1 receptor agonists as additional therapy, but I'm sure that they will move to first-line drug therapy after the results of the FLOW trial. So we have different options here, and also our medications for the treatment of type 2 diabetes, they already have indications for the treatment of people with chronic kidney disease, even being without diabetes. So I can discuss a lot about the advances in diabetes management. There is a lot to be said, a lot to be discussed, but for the sake of time, I would like just to conclude that technology has seriously entered the diabetes world. And we are living in exciting time, in time when we have totally changed the treatment algorithms for people with both type 1 and type 2 diabetes. And our focus now is on the option to prevent type 1 diabetes, or at least to delay the onset of stage 3 type 1 diabetes. But we are discussing a lot on type 2 diabetes. And one of the main goals in the management of type 2 diabetes is to achieve remission of type 2 diabetes, which is an important part of the international guidelines. So this is one of the main goals, and it is achievable. It is currently achievable through weight loss and through the use of the new medications. There is a real shift in the paradigm of type 2 diabetes management, and we have two groups of medications with protective cardiorenal, protective liver effects, and which are involved in all the components of care in the holistic approach of people with type 2 diabetes. So a lot has been achieved. We can apply so many of these advances in diabetes management in our everyday clinical practice, but a lot is ahead of us. There is a lot of advances which we are looking forward during the next years, not just for the closed loop system in people with type 1 diabetes, but with the new options which we have in the treatment of type 2 diabetes, with the dual, with the triple incretin agonists, which is also quite an exciting area in the management of people with type 2 diabetes, and also many achievements in the field of obesity as well, which is one of the main components and risk factors of people with type 2 diabetes. So a lot has been done, a lot has been achieved, and we are looking forward to have new advances I hope, in the near future. A lot of gaps have been already filled, have been already completed, and I think we'll fill new gaps in the near future. With this, I would like to thank you for your attention.
Thank you very much, Svetlana. We live in a very exciting time regarding the news in diabetes after so many decades of not many changes. And it was really a nice presentation. So we will move now to Professor Florian Totti.
Thank you, Tatiana. Thank you, Bansi and Amit, for inviting me. And thank you, Svetlana, for the nice opening of this activity, because it helps in my presentation, because we have seen a lot of changes for the diabetes treatment, and on the other hand, for the diabetes changing of behavior, there are some changes, but it is mostly related with new focus. Do you see my screen?
Yes, we can see your presentation.
Okay, so and thank you for inviting me to be at least virtually this time in India together with Banshi, Amit, and all other Indian friends. So my title of presentation is Lifestyle and Behavioral Intervention in Diabetes Care. It was on 2006 that United Nations has held a General Assembly and had a resolution on diabetes. And the main theme was to say that to do nothing more for diabetes is not an option. So what has changed since then? Actually, in Europe, there are more than 66 million adults with diabetes. And the estimated diabetes prevalence has seen an increase on being 9.8% in 2024, and it will be about 10% in 2050, with about 90% of adults with type 2 diabetes living with overweight and obesity. And together, type 2 diabetes and obesity account for global multimorbidity, premature mortality, and escalating healthcare costs. If we change the diet and lifestyle, we can prevent and control diabetes. So for this reason, we need to have a team-based care to improve outcomes and to reduce the cost for people with diabetes and the health system in general. So as Svetlana has already mentioned in her presentation, now we are talking about a holistic approach, not only for the treatment of diabetes, but also for the weight management, and to individualize strategies which include nutrition and exercise intervention, behavioral counseling, pharmacotherapy, and probably metabolic surgery, and some of the new treatments that we can use actually. If we manage the weight, we can delay the progression or even to prevent diabetes or to delay the progression from prediabetes to type 2 diabetes. And it is highly beneficial in treating type 2 diabetes because it reduces cardiovascular risk factors, lowers long-term cardiovascular and mortality risk, and on the other hand, addressing weight management in a person-centered, non-judgmental, person-first language, we can achieve more for people with diabetes. You can see almost the same thing as Svetlana has showed before, but in these slides, I'm more focused on the importance of 24-hour physical behaviors for type 2 diabetes, increasing stepping, sleeping better, and moving more, so using more physical activity. What we can achieve with improve this part. Okay. It's okay now? It's okay.
No, it's still with all slides, not on slideshow.
Okay, I'm trying again. It's okay now?
Yes.
Okay. Sorry for the interruption. So in this slide, you can see that if we improve, for example, the steps per day or even sleeping, we can decrease the level of glycemia, we can decrease the blood pressure and decrease also the glycated hemoglobin. On the other hand, we can decrease depression and we can improve quality of life. So prevention is better than cure. So even for the diabetes, it is better to prevent or at least to delay diabetes onset than to have already diagnosed diabetes. With lifestyle intervention, we can improve glycated hemoglobin, weight, blood pressure, and lipid profile, but it requires multidisciplinary support, including nutrition, physical activity, and psychology. And nutritionist has a leading role in structured lifestyle programs. With a decrease of 7% of the initial body weight, we can prevent at least 50% of cases with diabetes. If we increase the moderate intensity physical activities to at least 150 minutes per week, and if we can use patterns for a diet, but we need to mention that there is no ideal diet that works for all people with diabetes. We can prevent diabetes for at least type 2 diabetes for at least 5 years. And the use of digital tools and type 2 diabetes prevention programs has shown that they are costly effective and should be covered by insurance providers and or the state. The major randomized clinical trials have used largely similar dietary approaches, often characterized as the prudent diet, healthy eating patterns, more than strict diet. This energy restriction induced 5 to 7% of the weight loss, and it includes moderate total fat intake, reduced saturated fat intake, increased dietary fiber intake, with increasing of physical activity for at least 30 minutes per day or 150 minutes per week of moderate to vigorous activity. So we can use in this case what was the motto of the World Diabetes Day a few years ago: act today to change tomorrow. The dietary approaches to prevent type 2 diabetes has shown their results with the first studies in Finnish diabetes prevention program and diabetes prevention program in United States, where with intensive lifestyle intervention, weight loss, and increase in physical activity, we can reduce the risk of type 2 diabetes by 58% in 3 years. What are the main dietary patterns used to prevent diabetes, but also to have a better metabolic control in people with type 2 diabetes? We all know about Mediterranean diet with increased consumption of minimally processed plant-based food. And in Balkan, we are very happy that we have a Mediterranean, mostly of our countries have a more Mediterranean diet. Olive oil as the main source of fat, low to moderate intake of dairy products, fish, and poultry, and low intake of red meat. Desg diet is another kind of diet which is rich in fruits and vegetables and low-fat dairy products. Includes whole grains, so fiber, poultry, fish, and nuts. Vegetarian and vegan diet, it is very popular, especially in the city of Banshee, which is a vegetarian country. Exclude all animal-derived foods, and other vegetarian patterns may include certain animal products. Healthy eating guidelines or prudent dietary patterns, they include recommendation in higher content of fruits, vegetables, whole grain, legumes, and plant-based oils, with lower content of red meats, refined grains, and sugar-sweetened beverage. We can also talk about moderately low carbohydrate diet, which has shown in some studies to reduce the level of glycated hemoglobin, but also the weight of people with diabetes with reduced carbohydrate intake and increased consumption of fats and proteins of either animal or plant origin. So today we are talking about a new paradigm in diabetes care, which is multifactorial, person-centered management, and care delivered in an organized and structured way with a careful consideration of social determinants of health and individual preferences, including all the behavioral changes, with therapeutic goals about the education about the disease, for better metabolic control, to help the weight loss, to reduce the carbohydrate and energy intake, increasing physical activity, and to manage the comorbidities. And in this aspect, diabetes self-management as education has a key role in achieving all these goals that we have. Diabetes self-management education focuses on lifestyle behaviors, healthy eating, physical activity and weight management, medication taking behavior, self-monitoring when needed, and self-efficacy, coping, and problem solving. And it includes a multidisciplinary diabetes care team with endocrinologists in the lead, but with the help of nurses and diabetes educators, nutritionists or dietitians, psychologists or counselors, physical activity experts, and community health workers, because today diabetes and obesity is not just a chronic disease, but it's a health problem in all countries and in the whole world. What is important as a key change is the reinforcement of the important role of the registered dietitian in diabetes management and new information on the importance of using a transcultural approach to nutrition therapy with the goal of providing culturally congruent nutrition counseling, role of various dietary patterns, and some new habits that are very common, especially in Muslim countries, but also in the European countries where the Muslim population is increasing, Ramadan fasting, and diabetes. So the diabetes care today must integrate behavioral and pharmacological psychosocial elements, with the nutritionist playing a core role in implementing lifestyle and nutrition intervention. And it includes a holistic team-based approach when it is needed. So there are some of the counselors about people with diabetes. What we need to include recommendation about the nutrition, physical activity, and behavioral therapy with frequent counseling, with this 16 sessions in 6 months, and long-term weight maintenance program for more than 1 year to achieve the weight loss and to maintain the weight loss, and short-term structured very low-calorie diet, which should be reserved for carefully selected individuals with a very high BMI. If we lose 5 to 15% of initial weight, it would be a good starting point and the primary target for management of mostly people living with type 2 diabetes. 5 to 10% confers metabolic improvement, and 10 to 15 or more can have a disease-modifying effect and lead to remission of diabetes. Weight loss may expert benefits that extend beyond glycemic management to improve risk factor for cardiometabolic disease and quality of life. To promote and support healthful eating patterns, we need to emphasize a variety of nutrient-dense foods in appropriate portion sizes in order to improve overall health and specifically to improve glycated hemoglobin, blood pressure, and cholesterol levels, to achieve and maintain body weight goals, and to delay or prevent complications of diabetes, but always to address individual nutrition needs based on personal and cultural preferences, health literacy, and access to healthful food choice. And what is more important is to maintain the pleasure of eating by providing positive messages about food choices while limiting food choices only when indicated by scientific evidence. There are 4 steps in the medical nutrition therapy, which is the assessment, nutrition diagnosis, intervention, including education and counseling, and monitoring with ongoing follow-up and accompanying the patient in all stages of the behavior changes. You are all familiar with the macronutrient distribution of the total energy. About 45 to 60% is carbohydrate, 15 to 20 protein, and 20 to 35 fat, but mostly of unsaturated fat. I wanted to show just a short and simple example of how to use nutrition facts. We are in the case of cracker A and cracker B. The weight is about similar, but if you can see the number of carbohydrates is both similar, what changes is the fiber, which is more higher in cracker B, and on the other hand, the percentage of fat, which is lower in the cracker B than in the cracker A. And in this case, on the cracker A, the daily values of the fat is more than 50% of the daily values, and on the cracker B, it's less than 5%. So between these two cases, we can choose, even in the case of an unhealthy food, we can choose the healthier of both, of two of them. And about the healthy dietary patterns that we mentioned before with Mediterranean diet pyramid and vegetarian vegan diet pyramid. Mediterranean style dietary patterns has reduced major cardiovascular events and improves glycemic control. Vegan and vegetarian dietary patterns improve glycemic control, body weight, and blood lipids, including LDL, and reduce myocardial infarction in the studies. Dietary approach to stop hypertension, improve glycemic control, blood pressure, and LDL, and reduce major cardiovascular disease. Dietary patterns emphasizing fruit and vegetables improve glycemic control and reduce cardiovascular mortality. And what we need is to increase the dietary fiber in our nutrition and to use more pulses, whole grains, and fruit and vegetables in the on our nutrition of every day. And what is important also is to use low glycemic index carbohydrate instead of high index carbohydrates. So, for example, it could be breads and cereals, all bran, instead of bran flakes or corn flakes. Or in the other hand, we can use bulgur or pasta and noodles instead of brown rice or short grain rice. And we need to change our strategies based on the stages of diabetes. So in prediabetes, we must focus more in weight loss and maintenance and portion control. In the early stages of type 2 diabetes, in weight loss, portion control, and low glycemic carbohydrates. On people that are not on insulin, we need to focus more on carbohydrate distribution, low glycemic index, and high fiber. And then patients with insulin therapy, we need to focus more on carbohydrate consistency with especially a special focus in low glycemic index carbohydrate, and to know the dietary pattern for each of our patients, and to include also physical activity. On the other hand, there are a lot of medications that can help to achieve our goals, especially for the nutrition objectives. Some of them are very efficacy to lower blood glucose, but also the weight of the patient, as it is semaglutide and tirzepatide. High is dulaglutide and liraglutide, intermediate exenatide, dexenatide, and neutral is DPP-4 inhibitors and metformin. When we talk about behavioral changes, it is not only about nutrition, but it's also to increase physical activity and to try to do a minimum of 150 minutes of moderate to vigorous intensity aerobic exercise per day, including resistance exercise at least twice per week, and set physical activity goals and involve a multidisciplinary team if available. We can use aerobic exercise, start by walking and increasing the number of steps and the intensity of the walking every day, to progress over 12 weeks to up to 50 minutes per session, including warm-up and cool-down of brisk walking, and alternatively, shorter exercise session in the course of the day, for example, 10 minutes 3 times a day, after meals can replace a single longer session of equivalent length and intensity. And we need to include also the resistance exercise. We can choose 6 to 8 exercises targeting the major muscle groups, arms, chest, back, legs, and abdomen, and gradually increase the resistance until you can only perform 3 sets of 8 to 12 repetitions for each exercise, with 1 to 2 minutes of rest between them. Interval exercise needs to perform in alternating between higher intensity and lower intensity with shortened total exercise duration, increased fitness gains, and increased variety. We need to have, for example, alternating 30 minutes of very high intensity with 90 seconds at low intensity of the exercise. And what is the most simple way? It's to increase the number of steps per day. Here you have a sample step count prescription, starting with patients that are not active at all, with less than 5,000 steps per day. And we can increase gradually in every 2 or 3 months to achieve in 9 months to have more than 1,000 steps per day. And for people that are more than 7,500 steps per day to achieve in less than 3 months to more than 1,000 steps per day. There are some challenges that are always in our discussion with the patients, such as time constraints during physician-patient encounter, or pre-existing or suspected heart disease. But we can find some solution involving a multidisciplinary team of kinesiologists, physical therapists, diabetes educator, and if patient wishes to make an activity more vigorous than walking, evaluate with a history of physical resting, ECG, and possibly exercise ECG stress test. So instead of doing this kind of activity, we need to change totally the behavior of our patient, but in some cases to start with changing the mentality of doctors too. And for this, there are some recommendations that people with diabetes should ideally accumulate a minimum of 150 minutes of moderate to vigorous intensity aerobic exercise each week, spread over at least 3 days of the week, with no more than 2 consecutive days without exercise. Interval training, short period of vigorous exercise alternating with short recovery periods of low to moderate intensity can be recommended to people willing and able to perform it to increase gains in cardiorespiratory fitness in type 2 diabetes. People with diabetes, including even the elderly people, should perform resistance exercise at least twice a week and preferably 3 times per week, in addition to aerobic exercise. In addition to achieving physical activity goals, people with diabetes should minimize the amount of time spent in sedentary activities and periodically break up long periods of setting. What is important in people with diabetes is to reduce the risk of hypoglycemia during and after the exercise, especially in people with type 2/1 diabetes, following the 5 strategies that can be considered alone or in combination. Reduce the bolus dose of insulin that is most active at the time of exercise. Significantly reduce or suspend if the activity is more than 45 minutes, basal insulin for the exercise duration. Increase carbohydrate consumption prior to, during, and after exercise as necessary. Perform brief 10 seconds maximal intensity sprints at the start or at the end of the exercise. Perform resistance exercise before aerobic. So, as key takeaways, we can say that nutrition therapy is evidence-based, person-centered, and outcome-effective. Individualization and shared decision-making are essential. Nutrition is bridging the gap between lifestyle and pharmacological care, and weight management and diabetes education are now core therapeutics. High level of physical activity and fitness are associated with lower morbidity and mortality in people with type 2 diabetes. We recommend at least 150 minutes per week of aerobic exercise and at least 2 sessions per week of resistance exercise. Physical activity often improves glucose control and has multiple other health benefits, even if weight and glucose control does not change. It is best to avoid prolonged sitting. Try to interrupt sitting time but by getting up briefly every 20 to 30 minutes. So the journey of 1,000 miles begins with a single step. So it is better to start now to change this sedentary behavior that we have. And for this, we need also the education because, as Benjamin Franklin has said, tell me and I forget, teach me and I remember, involve me and I learn. And this is the most important part of education for people with diabetes. And that's why therapeutic patient education and diabetes education study group is very important. And we have just finished the November month with the World Diabetes Day, and I wanted to finish with a picture taken during our activities during the World Diabetes Day. Thank you for your patience. Thank you very much.
Thank you, Florian. We heard a lot of very useful advices on diabetes, nutrition, and physical activity. And finally, a bit of psychosocial element of diabetes. And Professor Cornelia, please, you can give us your lecture.
Thank you very much. I'm very happy to join this webinar, and I'm honored. And I prepared this presentation together with my colleague Andrea Mocan, who's a clinical psychologist in our team. So we are lucky to have her with us because or with her help, we can learn more and know more, and I hope do more regarding mental health in diabetes care. Mental health in diabetes care, of course, applies to all these huge numbers of people with diabetes in the world. And it was recognized already in 2015 in this position statement from the American Diabetes Association as an important dimension of care for persons with diabetes. And here I reproduced one of the slides used in this position statement, which shows us that there are a lot of phases of living with diabetes that we can or we should take into consideration, both from a perspective of symptoms or diagnosis of mental health problems, but also in terms of, let's say, non-pathological changes, but still affecting the well-being and mental health in patients, persons with diabetes. And another important message from this statement is that on one hand, all healthcare team members, physicians, nurses, diabetes education, dietitians should have this focus not only on clinical aspect but also on mental health aspects. And of course, the ideal would be to have specialists on behavioral and mental issues, such as psychologists or other health care providers trained in this area, and together to first identify mental health problems and of course try to improve the situation when changes are identified. And the same recommendations were also included since then in the well-known standards of care for people with diabetes issued every year by the American Diabetes Association, where we have quite quite detailed section dedicated to psychosocial care. And here the main recommendations are that we should implement screening protocols for different psychosocial concerns, and when identified and indicated, to try to refer these persons to behavioral health professionals, which in practice we must recognize in our region. And here I speak about our Eastern European region, and probably in India is not very feasible in daily practice. Anyhow, as physicians or healthcare professionals in general, we must recognize that diabetes comes with an important emotional impact on a person with diabetes, but also on their family members, friends, colleagues, co-workers, and that there are a lot of factors which can influence this emotional impact that ideally also should be identified and addressed in comprehensive interventions. And there is another interesting aspect coming from our psychologist colleagues, which talk about this diabetes crisis and the relationship with emotional health. And this diabetes crisis is described or defined as radically different from prior experience expectations than the normal repertoire that a patient not or person not having diabetes before would use to solve problems, and the resources that have been useful to them in the past, and that now in the face of diabetes diagnosis or diabetes complications are inadequate or inappropriate. And here are some examples that we all recognize in our clinical practice. A person at diagnosis or at the onset of diabetes that have a lot of feelings such as guilt or anger about diabetes, uncertainty about the situation, and all these feelings should be also taken into consideration by the medical team. And the same is true when the new diabetes complication occurs in the life of a person already diagnosed with diabetes. And if we think which is the relationship, let's say, between a person with diabetes and his or her disease, we should always keep in mind that a person with diabetes spends a very limited amount of time with us or with the medical care team, while the immense majority of the time they are spending trying to do a good diabetes self-management. And there are data showing that people living with diabetes think about their condition every 12 minutes on average, and that diabetes or diabetes control depends almost entirely on behavioral self-regulation, and that should be recognized, and it is recognized in studies, as one of the most psychologically and behaviorally demanding among all other chronic diseases. And speaking about mental health in diabetes, we should also recognize that there are two different areas. The area which is usually more easily recognizable, where we speak about the existence of psychopathology. And here we have depression, so the clinical depression, anxiety, and eating disorders, which are considered as adds to everyday life with diabetes, so a concurrent condition. But on the other hand, and this is directly related with diabetes, there are situations which are not considered pathological, but still interact heavily sometimes with the everyday life of a person with diabetes, and also puts pressure on person with diabetes and their family. And here we have these specific aspects, which is diabetes distress, diabetes burnout, and disorder eating, which is different from eating disorder. So disorder eating means pattern, let's say, of food intake which is not at all organized or which is disorganized, as it was also mentioned by Professor Totti. And in terms of prevalence, depression is twice as common in diabetes compared to general population, while around 1 out of 3 persons with diabetes which will experience diabetes distress. And here are some details of what diabetes-related distress means. And it is defined as an emotional response to the specific burdens of living with diabetes and having to self-manage diabetes. It can be dynamic, so we should not expect the same level of diabetes distress throughout the course of life with diabetes. And it should be also or stressed again that it's not considered a condition, a pathology, a disease if you want, but it is clinically relevant for what diabetes self-management is supposed to be. And the presence of diabetes distress is recognized as a barrier to self-management and is associated with higher HbA1c values. There are a lot of distress sources which at some point make a person with diabetes feel powerlessness, and this should be again recognized, and an intervention should be addressed to this situation. And here is an example that Andrea produced, let's say, or proposed, to differentiate between major depressive disorders, which is a clinical condition, and a severe condition in some situation, and the diabetes distress, which is similar somehow, but it's directly related with living with diabetes. And if we look at these two aspects which are presented in parallel, you can see that diabetes distress is related with living with diabetes and all other aspects, such as concern about food, which is related to diabetes control. And the instruments to identify these two aspects are different. Of course, the interview is useful for identifying both conditions, but there is a clear need for a trained healthcare provider to be able to do these interviews and to identify one of or the other condition. And very recently, maybe those who participated or followed the recent EISD Congress, which was held in Vienna this year, know that in two sessions, there were presented aspects from a new guideline, which is practically the first AISD guideline dedicated to assessing and managing diabetes distress among adults with both type 1 and type 2 diabetes. And Andrea is one of the authors of this guideline, which is announced for early 2026, so next year in 1-2 months. But there are the presentations which were given at AISD and also still available. And I put here the link to the final draft of these guidelines, which were posted and put into discussions on the AISD website. It's a complex document, I think very useful for both clinicians dealing with diabetes, but also for clinical psychologists who need a specific education on how to manage patients with diabetes and diabetes distress, which is a specific situation that should be well understood also by psychologists. So it's a complex document. We only selected a few aspects. There are two main domains that were addressed in this guideline. The first one is how and when to assess diabetes distress. And the second one is dedicated to the effectiveness of psychological or other types of interventions for reducing diabetes distress. So you will find 8 good practice statements for assessment, 9 recommendations for the management of diabetes distress in type 1, and another 9 for diabetes type 2. And here I put an example of the 9 recommendations regarding interventions in type 1 diabetes. And of course, even this small table is complex. Anyhow, there is a clear delimitation between the role and place of psychological intervention, educational intervention, which is not the same, and one should not replace the other. And also, interestingly, the fact that using CGM is also a way or a method to reduce diabetes distress among type 1 diabetes. And here are a few general recommendation and a few aspects that are presented in this guideline, addressed to medical team, addressed to psychologists, and also addressed to people with diabetes. And for the last 1 or 2 minutes, I will invite Andrea to present a few take-home messages.
Thank you very much, Professor Bala. And I would like to thank you everyone for inviting me today. It's a great honor. What I would like to say is that education and psychology are sister, in my opinion, in what diabetes is. And I think we need to try to combine in the future both of the ways we have here. One of my take-home message is both for medical doctors or nurses, but also for psychologists, and especially for people with diabetes, because I think we need to take into account that diabetes distress, it is an obstacle in glycemic control. And talking about diabetes distress, even if it's not psychology and even it's not psychopathology, it can be a big obstacle in what Professor Totti said before, diabetes management, diabetes behaviorals and self-care management of diabetes. So we need to take into account when discussing about diabetes, and the guidelines offer a few recommendations on how to address, how to screen for diabetes distress, and it's very important for doctors to talk about diabetes distress in routine consultation when the patient feels the need to talk about diabetes distress. But also, I think it's important for people with diabetes to be used to talk about their emotional impact of diabetes, and to be not feel afraid or ashamed about having diabetes distress, because actually in the end it's something normal. It's a normal reaction that we all have to a disease or to a situation. And for example, for Romania, diabetes distress in type 2 diabetes present around 60%, so it's not something that is new or uncommon. And I think and I believe the figures are almost the same around the world. Maybe, I don't know, but maybe in India might be a little bit higher, because the healthcare system, it's a little bit different. That's the system in Europe or the system in the US. And to normalize discussing about diabetes distress, almost, I cannot say it solves the problem, but when you acknowledge and when you discuss about the problem that you are having or the challenge that you are having, it is not solved, but is the first step we need to do. And for be able to do this, I think both the members of the healthcare team and psychologists, but also people with diabetes, need to know what diabetes distress is and how they can be helped. So in the future, even if diabetes distress is fluctuant or pervasive or comes and goes, it needs to be acknowledged. Because if it's not something that we talk about and it lingers, it can go to diabetes burnout. And we know that diabetes with burnout, if it's not, let's say, discussed and solved and treated, it can be depression can be developed. So in order not to go to psychology, in order not to go to psychopathology, it's better to prevent it. So talking about diabetes distress would be preventing. So thank you again
Thank you
for
very much.
the
Yeah.
invitation.
Thank you so much. It was very interesting. And now, Dr. Amit Gupta to say a word.
Just to share good news that we were having 380. So not 300, it is 380. Just I asked. Myra, I know, and मैं तेरे को बाद में phone करूँ.
Yeah, thank you. Thank you, Dr. Tadzana. Thank you, all the esteemed speakers. And we really had enjoyed all the talks and learned so many new things. And it was great to learn from your experience from the Europe and the different parts of the world. So, RX team, do we have any question in the chat box? If you have any question, then please give us the questions. So I don't see there any.
Aryan, can I start with some questions?
Yes, why not?
Yes. So one which we always see, that here patient expectation from doctor is for everything. Even now we have in our clinic, I mean, those clinic which are tertiary care or even secondary care, like me and Amit have, dedicated nutritionist or an educator, explaining them everything. And we ask them to go and meet our educator and our nutritionist for explaining other aspects. And even I have diabetic foot nurse, but still at the end of the day, patient get, again, all the questions they want to ask again the doctor. And that is also one of the reason that many times they don't want to educate it, they don't want to give so much time to the persons with diabetes. So what's the situation in your country, how you manage that? Because here already we have most of the consultant and physicians have more than 40 patients in a day and busy OPD, how to deal with it. Otherwise, also, it takes 5 to 10 minutes for history. Sometime in new case, it may take more. Some other comorbid condition, then other more time. If type 1, or like if I have to explain patient about pump and CGM, then again it takes more time. And we have, our patient have to pay from their pocket. So that's again a explanation regarding the cost of therapy too. So how you manage? Is there any systemic education program or some tick box that these things has been already checked out? We want to create some sort of a education pamphlet and a checkbox type of system for Indian physicians or Indian diabetes clinic. Florian, over to you. सबको
So if you are talking about something prepared or used by Diabetes Education Study Group, we have some leaflets and small 5 minutes toolbox, we call it, about different issues on diabetes education for people with diabetes, starting with the diagnosis and prevention of diabetes, continuing with monitoring of diabetes and examination that the patient has with diabetes needs to perform, and after that, the prevention of complication. And we are trying to update some of them in the recent year, and even also to include some new aspects as could be, for example, technology and diabetes, because it is something that nowadays everywhere, and it is very important for people with diabetes to have the right information, to use the right applications for it. For this, we have some materials and we need to update them. And I hope that, and I invite you as India diabetes care to be involved in the process, because diabetes is a worldwide problem. So it is not a European problem, but it's for the whole world. And I think we need to have different point of views and opinions from different countries, because even the level of education could be, as it is said by the WHO, the basal or the minimum, the normal and the high level of education, of high standard of education. So for every people and for every health system to have these 3 levels of education. And for this, I can say that we have some materials, but it can be used or be improved with your experience based on your practice of every day, because it can be completely different from Albania or from Bulgaria or from Romania. And you need to have some local tools about it, but surely it's better to have the same language and the same message from all parts of the country. I don't know if Tatiana want to add something more about it as the president.
I agree with you that we have to tailor-made the education material, but still, because even if we make for Diabetes India, individual clinic will require a different model of working too. But still, if we can have some rough idea which you are using and which we can endorse with DSG and Diabetes India together, I think it can be useful. Tanjana, you want to make any comment?
Yeah, of course, I'm agree with you. We are trying to standardize all this, and like we used to do before, but we will do that, and also we are aiming to make some official recommendation, like European, like WHO started to with diabetes education, so it must be unified and it must be like an official recommendation that will be together, or that will be unified in each part of in every part of at least Europe, and of course wider if it can be accepted. So India, like our partners, so we will include you if you want
Yes,
to
sure. Part of it.
to make these guidelines or these recommendations acceptable for our healthcare providers. So it can be then easier to spread this idea to every place where there is the cure for diabetes.
Great. Tanko, one question is there that in your country, is that insulin pump therapy, is it available to every child? Is it given from the government side or some insurance is required? Because in India, they have to pay from their pocket. So, you know, the education, almost a half a day or sometime even more, even we explain every aspect of the benefit of insulin pump therapy, particularly AID, but still it is very difficult.
So I think it's different in different countries. So insulin pump are not available for every
Everyone.
patient with type 1 diabetes. It depends on country. It depends how much money are in the healthcare fund to pay. Sorry?
So,
Sorry, I think Dr.
I
Tanko
don't
wants
know
to answer.
how the situation.
In the different countries, it's really different. It depends what is the availability of these pumps and the affordability. Because it was in Bulgaria as well that patients had to pay everything for the pumps, let's say till 10 years ago. Now we have the pumps there for free, but for the hybrid closed loop systems, we have just maybe 50 or 70, something like this. It is quite expensive, but we have the support from the authorities, from the health authorities, to implement them in clinical practice. There are some European countries where the pumps are available for each and every person with type 1 diabetes. It is in the guidelines. And really, it depends on the priority of the healthcare system. But it really works. What we have as an experience from the hybrid closed loop system, it's really very good. But it's expensive if one has to pay himself out of pocket for all this. Patients in our country, they get it for free and they need to pay every month 150 euros for the consumables. And even this is quite expensive for some of them. But we hope to improve in the future. At least the first steps have been done. And in the countries, we need to, yes, we need to push forward, but of course it depends on the financial situation.
And what about the screening for who are at the risk of developing type 1? I mean, the persons with type 1, are you screening for their relative or first blood relative or this other brother or sister? Are you doing it in your country?
In Romania, no, but we plan to do that because already all international guidelines are
But only I think I believe in Europe it is only the Italy who started for universal screening, or is any other country who's doing it?
It's Italy, I think they are doing already this screening and
as far as I know, in Slovenia, they are doing also for type 1 diabetes.
That's great.
In Slovenia, and I'm
You
not.
think the screening for
Type 1.
Is screening for first degree relative of type 1, who is at the risk, by doing their autoantibody. The challenge is in India, sometimes patients are affording and we can ask them to get it done because it is not really a part of universal screening, because they keep on asking, is there a possibility that my other child will develop or not, or whether that we can ask them to get their autoantibody. It's not, because it is available, they have to pay from their pocket. But the problem is if it comes positive, if there are 2 autoantibody comes positive, then what to answer? Because we don't have Tepezimab which is available. It's costing very high and we can't send the patient to take it from USA. So that's some challenges are there. And that's the reason we don't promote it. Rather, we just reassure that don't do anything unless it is required.
No,
in your country also, when it is not a screening program, then how you handle that aspect, because that's an important education point where patient relatives keep on asking you that whether my other son or my other daughter, whether I have developed, so will my child will have type 1 or not? Because many times this is a common question. Whether they should have child or not, that is also very
Parsha, this is very difficult question because we cannot use genetic for screening, and usually the screening in some countries are general. So all kids should be screened up to some age, and then it's another problem what to do with all this. You have to have money enough to offer them teplizumab, which is not the case with most of the countries. So I know that couple of countries like Slovenia, smaller countries with prominent persons like Tadej Batelino, they made an universal screening for kids up to age, I don't know, from up to 50. I'm not sure for the upper limit. But then there was a problem that they were not able to give the drug free of charge for all these kids. So it's still a lot of questions regarding the teplizumab and availability for, well, especially for your country. I don't know. It's so huge country. You cannot rely on genetic because it's not quite genetic illness. So you should screen the whole population, which is
so
almost
difficult.
impossible
Yeah,
for bigger countries.
So
with
Yes,
such
I mean,
population, it will be very difficult. But now I think there is a consensus coming on screening for type 1 diabetes with these autoantibodies. But if you do not have to offer something to these people, then we may create a bigger distress for these people.
very
Because
true.
you will know that you have people who are at risk in the family. And I'm thinking sometimes whether the benefits are enough and whether the burden will be reduced or will be increased with such a screening. But things are going in this direction. And there is something which we can offer. Of course, in our countries, we cannot offer this medication now. And then it comes out that people will know years before they get type 1 diabetes to live in stress, because what can they do at this time? Yes, they can improve, for example, lifestyle or things like this, but the different countries, it's really different. Still, we have an option, and that's why it's an achievement in the field of diabetes, but it's not applicable in many of the countries in the world.
So, very interesting
I
discussion happening.
completely agree.
So I would just like to give some information and agree with all the panelists that type 1 diabetes screening, it is something which has come up more recently. And obviously we have teplizumab to be offered. And I was part of an ADA roundtable, and we developed education material for the practitioners and the general physicians and the offices what they should display. So the two school of thoughts that the idea of screening is not to just to give teplizumab. Idea of screening is to identify the people who are at risk, and probably this gives us a window which may vary from few years to few months, where we can actually prevent these patients landing up in emergency in hospital with DKA. So idea is that you know better, so you get more time to prepare the family, you get the time
Yes.
to guide them regarding the therapy, and they don't end up in the ER with the life-threatening diabetic ketoacidosis. So that is the idea of screening. And obviously, screening protocol vary from country to country, and different economies they will handle it differently. But
I'm not convinced that it is cost beneficial. I'm
yeah,
not convinced that you should screen all the population. So to find a few, you cannot offer them a drug,
yeah,
and from the other side, they are expecting something that that it is inevitable. So for me it's a huge moral dilemma. So we will see what will say, because if it is drug that can delay type 1 diabetes for 10-15 years, then maybe it's worth to ask even
yeah,
family to pay for the drug. But for up to 2 years, this is I must say that I'm not convinced that it is cost effective and it is for a wider use. It is it's a very big achievement. It is the first drug that shows at least something, but still not enough to invest so much money for something that it's not so
I think you're right, and the
promising.
cost effectiveness will always be a question. But at least what is now the experts are talking that at least you offer it to the families who already have a kid living with type 1 diabetes or someone is already diagnosed. And at least in those families, you can screen. They're not saying give the drug, but at least the screening should be happening for the siblings who are having type 1 diabetes just to make sure that they again don't end up in the ER with diabetic ketoacidosis and all. Universal screening, you are rightly mentioned, if your government has the money to spend that kind of money and give Taplizumab. So I think Italy is one of the country where the universal screening they have recommended, and they recommend screening starting from the age of 3 years, and they have a different program where they screen up to the age of 18 years, multiple times a child. So I think it again depends on the health of your healthcare system and the financial health of your healthcare system.
But Amit, that question is very right, that even it increases the distress level very high. So those who are diagnosed, you think of those who are non-diagnosed, and those who have one autoantibody positivity. Forget the two, because two is an indication for them to start. We understand that this is a disease-modifying therapy, and this debate is very much common in SPAD. Since the last 4 years, diabetes distress maximum increased when you have a child who has the increased risk of developing type 1 with one autoantibody positive and not two, and then you can't offer. Or even in the countries where, like in India, some patients, they go and they ask for all two autoantibodies. Suppose they come positive and you don't have anything to offer them. That's really a challenging situation for the clinician. But education is still a very, very difficult task, rather I will say, a time-consuming for clinician. And we always focus on a therapy or the therapeutic table, but we forget on the right side, even ADA-ESD guideline also put very nicely that what are the education which we should do in our clinic. But that's the reason, but we learned a lot. And now I request Amit for proposing vote of thanks, and thanks to everyone. Over to Amit.
So I think we had a very interesting discussion and more focused on type 1. Obviously, we will find some time to discuss other things in the diabetes education. Maybe a next webinar will be required. And thank you once again, Dr. Tadzana, Dr. Enkova, Dr. Cordelia, and our dear friend, Dr. Florian and Dr. Andrea, for extending your support to Diabetes India and jointly organizing this webinar. And we had more than 350 participants, 380 participants, as Dr. Bansi has already mentioned. The recording will be available on the website of Diabetes India, and we will share the files with you as well. If you wish to publish it on your website, webpage as well, you can do that. And we hope to see you soon in India in Diabetes India Congress 2026 in February. And I'm sure many of you will be able to join us. All the participants, those who are listening, I would just like to mention that application for the Fellowship of Diabetes India is now open. You can apply it. They will remain open till 31st of December. And we are accepting the abstracts for the Diabetes India right now. So please do submit your abstract. Thank you once again, our Secretary, Dr. Bansi Sabu, our President, Dr. S.R. Arvind, Dr. Sanjay Reddy, and all the leadership of Diabetes India. And again, heartfelt thank to Diabetes Education and Study Group. And we believe that diabetes education is the most important pillar when it comes to management of any type of diabetes. So great work, all of you guys. Thank you. Thank you very much.
Thank you.
Thank you all also for the invitation. It was our pleasure, like always.
Thank you.
Bye.
Pleasure.
See you